Hello and welcome to the Greater Manchester Healthcare Academy NHS Smoking Cessation Service webinar. My name is Ricky Smeaton and I'm the Principal Responsible Officer for Greater Manchester LPC, and I'm joined by two colleagues who will also be presenting this evening. Al, do you want to introduce yourself?
Thanks, Ricky. Good evening. My name is Alison Scowcroft. I am a Senior Medicines Optimisation Pharmacist with Midlands and Lancashire CSU, supporting the rollout of the Smoking Cessation Service across the North West. And I also have a role in Greater Manchester working for CHL, which is the pharmacy provider company, also project lead for Smoking Cessation Service rollout in Greater Manchester. So here with two hats on.
Thanks, Alison. And Florence, would you like to introduce yourself as well, please?
Yeah, good evening, everybody. My name is Florence. I'm one of the stop smoking nurses at TAMESIDE Hospital, presently working with Cure.
Brilliant. Thank you, Florence. Next slide, please, Al. So the webinar this evening has been developed by the Greater Manchester Healthcare Academy, which is a partnership between NHS England and community pharmacy, supported by key education and training providers. And the main focus is engaging and supporting our community pharmacies to achieve their full potential in service delivery. We do run an extensive range of training and events for our community pharmacy teams. The whole team is supported, most of which are free to attend. The founding members of the Academy are listed there on the screen. So the Greater Manchester Health and Social Care Partnership, the Greater Manchester Pharmacy LPN, Greater Manchester and Bolton LPC, and of course CHL, the Community Pharmacy Provider Company, and also supported by CPPE. Just a couple of housekeeping rules for this evening. There's quite a lot of information that we want to get through. So just to avoid interference, if you can put yourself on mute, which I think most of you are, thank you very much. If you have got any questions, please do feel free to use the chat box, or if you feel you want to, we will open it up to the question and answer section at the end. Please feel free to come off mute and ask us in that section. Next slide, please, Al, thank you. So the agenda for the evening, quick introduction. I'm going to hand over to Alison in a second, who will take us through the service overview. She'll then hand over to Florence, who will kindly take us through the role of the Cure team in the hospital. And then she'll hand over back to me, and I will take us through some of the service delivery and farm outcomes information. Thank you, Al.
Thanks very much, Ricky. So a couple of points from me. I'll give you a little bit of background to the NHS Smoking Cessation Service, particularly around the long-term plan and the Ottawa model of smoking cessation. I'll talk to you a little bit about some of the pilots that we had for this service before national commissioning of the service, and then a bit of an update on national implementation. So I'm sure everybody is aware of the NHS long-term plan, and prevention is a core component of the long-term plan. So the plan sets out the NHS's contribution to tackling tobacco dependence, and the key parts of the long-term plan that are relevant to us for the SCS is that by 23-24, all people who are admitted to hospital who smoke will be offered NHS-funded tobacco treatment services, and that is for acute trust, maternity trust and mental health trusts. So these commitments are designed to be the NHS's contribution to helping to deliver a smoke-free generation. They build on the good work that's already been delivered and are intended to complement current stop smoking services. There's a focus on both physical and mental health services, which is really important, and they introduce a level of national direction, but with local development and delivery. So we know that smoking cessation programmes already exist in community settings, but they are variable in their involvement of community pharmacy, and that's certainly the case across Greater Manchester. So hospital cure teams, such as Florence and her colleagues at Tameside, have adopted the Ottawa model of smoking cessation. So that must be adopted throughout England, and it is part of the NHS long-term plan, and it's led by the NHS England prevention team. So Ottawa model of smoking cessation is a 12-week programme which specifically requires follow-up of smoking cessation treatment after the patient's discharge from hospital. The data shows that it increases one-year quit rates by 11%, and it's expected to save the NHS £85 million within 1 year. So the aim of the NHS Smoking Cessation Service is to support delivery of the prevention ambitions in the NHS long-term plan, and for community pharmacy to become a nationally available choice for patients to access smoking cessation support post-discharge. So we had some pilots that took place in 2020 and 2021 to test the electronic referral pathway from hospitals into community pharmacy. And we were really lucky in Greater Manchester to have one of the pilot sites, which was very successful. So we worked with the Cure team at the Royal Oldham Hospital and set up a referral pathway for them to refer patients on discharge to 12 community pharmacies in the Oldham area, so just across the border from you guys in Tameside. We selected those pharmacies following an expression of interest process and made sure we had good geographical coverage across the different PCNs and extended opening hours. There was then a second pilot area that went live a little bit later in 2021, and that was in the Lambeth and Southwark boroughs of London, working with Guy's and St Thomas Hospital and King's College Hospital. And all those pilots have now transitioned into the nationally commissioned service. So just to give you a bit of an overview of some data from the pilot, this is data from the Oldham pilot. We had in just over a year, we had just over 200 patients who were referred to community pharmacy. That led to 81 patients being enrolled into the programme. So 81 patients attended their initial appointments and started their follow-up support with the community pharmacy. So that's a conversion rate of about 40%. Of those 81 patients, we had 46 with a 4-week quit, successful 4-week quit, and that quit rate was 57%. We then had 19 further patients who took it to a 12-week quit, a 12-week quit rate of 23%. And when we compared those statistics and figures with patients who were referred to the local community service, so not the community pharmacy service, but the locally commissioned service, the numbers were very similar. So the outcomes from referrals to community pharmacy were much the same as patients who'd been referred to the community stop smoking service. The pilots were then transitioned into the nationally commissioned service. So the NCSCT, National Centre for Smoking Cessation and Training, developed a standard treatment programme specifically for this service. PSNC and NHS England did their negotiations and agreed the service specification and the funding for the service. So the consultation fees are paid out of the community pharmacy contractual framework, and any NRT that is supplied through the service is recharged back to the ICB. The service was then a soft launch back on National No Smoking Day in 2022. So it has been launched just over a year now. It was an intentional soft launch because at that time, the status of all the different trusts around England was very different in terms of whether they had their inpatient tobacco dependence teams or cure teams in place. Now we're a year on, we're in a very different situation with the status of those tobacco dependence teams, and so the rollout is progressing. We're very lucky in Greater Manchester, we're a little bit ahead of the curve. I think we had all of our inpatient tobacco teams in place quite a lot earlier than some other areas of the country. So we like to do things first in Greater Manchester, don't we? So Midlands and Lancashire CSU have been commissioned by NHS England to support the national implementation of the smoking cessation service. And the role of the CSU initially is around scoping and mapping, so understanding which trusts are where they're up to in terms of their delivery of the relevant parts of the long-term plan. So that's them implementing their inpatient tobacco dependence service, and then identifying key stakeholders who we need to work with to set the referral pathway up. We then facilitate implementation at a local level, so there's an advisor available for each region, and we engage with those trust sites who are looking to start delivery imminently. And there's lots of supporting documents and promotional material that's available for pharmacies and for trusts on the MLCSU website, which is linked at the end of the slides, I think. So we've got 3 stages to go live. The first stage is that scoping and mapping, initial engagement with the trust, understanding who we need to talk to, setting up any working groups. Stage 2 is pathway agreement. So for Greater Manchester, that was a really quick and simple stage because the decision was made at ICS level that farm outcomes was going to be used to make all referrals from all trusts in Greater Manchester. And that procurement of the farm outcomes licence was done at ICS level. So that bit was really easy. It took a little bit of time, but once we got that farm outcomes licence in place, we were able to switch trusts on quite quickly. The third stage then is community pharmacy engagement. So working with the LPCs to make sure that the pharmacies in the area who are registered are set up and ready to provide the service, to make sure we've got good geographical coverage for Florence and her team when they start making referrals to pharmacies across Tameside and wider into Greater Manchester as appropriate, and also to do an engagement session such as this evening, just to make sure that everybody's got all the information they need in order to be able to start providing the service. So the pathway is very simple. There's a patient admitted to hospital. Florence and her team identify that somebody's a smoker and support them with a quit attempt. And then when the patient is discharged from hospital, they can be either referred to community pharmacy under the SCS service. They can also be referred to the locally commissioned service, or the patient may decide to opt for self-care, that they don't want any sort of referral on discharge. The model of care is on this slide, and you should recognise this from the service specification. So this just goes into a little bit more detail about how that transfer of care works. So the red boxes at the top are in Florence and her team in Tameside General. So an admitted patient's identified as a smoker, and treatment is initiated by the cure team with the patient's consent. The blue boxes across the middle describe that transfer of care from the hospital trust into community pharmacy. So the patient agrees to a referral to community pharmacy on discharge, and they designate which pharmacy they want to be referred to. When the patient's discharged, then Florence and her team will send that referral through on farm outcomes. And then the pharmacy must make contact with the patient within a defined period post-discharge, which is 5 working days. We then transition into the green boxes at the bottom, which is when the patient has fully transitioned into the smoking cessation programme provided by the pharmacy. So that's when they've attended their initial appointment with the pharmacy, and you then continue their support up to 12 weeks. And the final step is that post-event messaging, which is used to update the trust and the patient's GP on the outcomes of their quit attempt. So just to pull out a few important bits from the service spec for the community pharmacies on the webinar this evening. This service is intended to complement existing locally commissioned stop smoking services. So if your pharmacy is commissioned to deliver the locally commissioned service, you can continue to do so and continue to deliver that service as you have been doing. This will happen alongside. You can only see patients in the SCS service who have been referred from the trust and who wish to initiate or continue their quit attempt post-discharge. Really important point, you must make contact with the patient within 5 working days of receiving the referral. You must make at least 3 attempts to contact the patient. And if you're not able to contact the patient, then you must inform the trust, and you'll do that by dropping or rejecting the referral in farm outcomes. You provide support for the patient for up to 12 weeks, and you can deliver consultations either face-to-face or remotely, no more than 2 weeks apart, so usually weekly or fortnightly, dependent upon the patient's needs. And you make that NRT supply maximum of 2 products from the agreed list of GSL products in the drug tariff, maximum 2 weeks at a time. So this is a behavioural consultation with the patient along with NRT supply. You must make a clinical record of all service activity, and farm outcomes is probably the best option for you because you're getting referrals directly into that system. If you are delivering consultations face-to-face with the patient, then you should be using a carbon monoxide monitor to support that consultation and help with the patient's motivation to quit. There's no charges to patients, even if they do pay for their prescriptions. All the NRTs must be supplied free of charge. And you do need to return patient level outcome data to the trust, and that's part of the service specification. But in Greater Manchester, because we're using farm outcomes to send the referrals, you don't physically have to do anything because the data is all there for the trust to log in and see for themselves. And Florence and her team, we're going to do a little bit of a session on reporting in the next couple of weeks, just so that they're familiar with all the data that they can see in farm outcomes, which is really rich. So everything that you input into farm outcomes when you see these patients will be visible to the referring trust. In terms of fees, if you've registered to provide the service on the MYS portal, then you will have received a setup fee of £1,000. That covers all of the training that you need to do to deliver the service, along with purchase of an appropriate carbon monoxide monitor. Do check on the PSNC website for a list of approved monitors. You then get £30 for the initial consultation, £10 for each interim consultation, and £40 for the last consultation, which can be any time from week 4 to week 12, and the claims should be submitted on the MYS portal. In terms of training, you need to have completed your NCSCT Stop Smoking Practitioner certification. If you've already done that for another locally commissioned service, then you don't need to repeat it. There's also some specialist NCSCT modules around people with a mental health condition, pregnant women, and e-cigarettes. You need to have completed all of those as well. I mentioned earlier that there is a NCSCT standard treatment programme that's been developed specifically for this service. You must have read that, and you must use that to support consultations with patients. Really, really valuable resource. I would recommend that you download it, have it printed off, have it to hand when you're delivering consultations with patients. It really takes you through all the different things you need to talk about in that behavioural consultation with the patient. It takes you right through from initial to 4-week quit to 12-week quit. So a really valuable resource. And of course, you also need in place a carbon monoxide monitor and a standard operating procedure for the service. In terms of trust in your area, it's looking really nice and green on this spreadsheet, which is fantastic. So we've just got Tameside and the Christie left to go live with this service. Tameside are going to start making referrals in the next couple of days after today's webinar. And then the Christie, we're just waiting on a go live date from them. They're all set up and ready with farm outcomes and trained, ready to go. We're just waiting on a go live date. So I anticipate that will probably be sometime in April. So some pharmacies in Tameside may already have received referrals from other trusts across Greater Manchester that are live with the service currently. Just a bit of a map to show you where all the pharmacies are. It's probably not very valuable, but we've got over 300 pharmacies across Greater Manchester signed up. So around about 50% of pharmacies have opted to deliver this service. So we've got good coverage in most localities of GM. Couple of resources there for you, some links. Please check the PSNC page for the service. There's loads of useful information on there. You can get a link to the spec. There's also a link to the MLCSU website, which has got the dashboard and lots of resources on there as well, and the link to the standard treatment programme, which I mentioned before. So that's me for this evening. I'm going to hand over now to Florence, who's going to take you through the trust end of the service and how things work. Over to you, Florence. Thank you.
Thanks, Alison. So, hello everybody, my name is Florence. We'll be introducing the team and who we are at TAMESIDE. So we made up of Pamela O'Brien, who is our lead, and she's an alcohol specialist nurse, but she's our lead nurse for the team. I also have Donna Woodward, who is also one of the team peer nurses at TAMESIDE. Myself and our project coordinator, who is Sarah Miller. I believe she should be on this call as well. Next slide, please. So in Cure, what we do at the moment is we get referral for every patient that comes into the hospital identified as a smoker. So even if we don't get the referral from A&E or from the wards, we go through every note every day just to make sure that we identify everybody that smokes and we're able to reach out to them, because we're trying to make every site, hospital site in Greater Manchester a smoke-free site. In order to make TAMESIDE Hospital a smoke-free site and enforce it, we have to make sure they have nicotine replacement. So even if the patient does not want to quit, we still make sure they get nicotine replacement while they are in the hospital. So we do follow a couple of pathways. For every patient, they do get nicotine replacement. And when doing the assessment, we ask them, do you want to quit on a long term? That's where we go through the main process of referring them on to the community service when they get discharged from the hospital. So what we do for those who really want to quit, who don't just want the nicotine replacement for why they are in hospital only, we make a plan for them on how the best that works for them. So when we're giving them nicotine replacement, we don't just give them just the patch, a 21 milligram patch, or maybe a short acting as well. We try to get the best nicotine replacement that works for them. Part of our assessment sheet, we kind of find out what they've used previously in the past, what's worked for them, or what they would like to try. And we keep trying to change their short acting to get the best one working for them. So each individual, we try as much as possible to get a personalized plan for them. And also, we ask the patients why it's important for them to quit. That's for those that really want to quit. Because when you have something motivating you to quit, we kind of use that as an anchor for the patient whenever we go to visit the patient. I do understand that most inpatients are for short stay. So it's very easy for us at that point to motivate them for a couple of days. But when we refer them on also, what we tend to do at the end of this webinar, we also say we do continuous calls. We know we've transferred them to the community for support, but we just try to reach out to them because we've come to realize over time that it's important for the first person who initiated that contact with the patient to find out, do you want to quit? Once you give them a call, they kind of feel, oh yeah, I'm doing well, or I'm not doing so great. So we've already created that initial rapport. So what we do is if we find out the reason why they want to quit, we kind of use it as a motivation for them. So what cravings do they get and what triggers this craving is also part of the discussions we have when we're making an assessment and during their care while they are in the hospital. Because if we can get what triggers their cravings, we'll be able to find out how to help them overcome those cravings and those habits and those particular times where they crave more. Also, we have support network for them when they get discharged. We let them know that for those that really want to quit, sometimes once you've given them that initial assessment, when you go back for a follow-up visit, they will tell you, yeah, I'm doing okay while I'm in the hospital, but when I get home, that's where I'm worried. I'm in a different environment. I'm back to my old routine. I am going to struggle. So we always get them a support network at home for them, which is not mostly Be Well Tameside and Live Life Better Derbyshire at the moment. But with the farmer outcomes, they're going to have more support from the community. We also do social prescribing referral for some of them, or we give them information on how to get social prescribing done. Because most times the reasons we get why they go back to smoking is loneliness. And if social prescribing could help with that, it takes off one of the triggers for their craving as well. Apart from the social prescribing and the community support, we also offer NRT to them to get them through the bad times. Because once you have that NRT there, all types of NRT, apart from the nasal inhalator, the nasal spray, I think we have almost every other NRT available in the hospital at the moment. And with the support from Cure Greater Manchester, we're also planning to get vaping kits into the hospital, which is it's work in progress. And once that comes, it's going to also help boost our patient support for them to stop smoking. Yeah. So we give some of them financial benefits why they should stop smoking. Sometimes we give them ideas of saving the money in a jar for holidays, or just keep the money aside and be able to record what you're getting. It's just more of just let them know what financial benefits they're going to be getting once they stop smoking. And if you encourage them to save, they're able to, I think one of my patients once told me that they were able to get something, they were able to plan a big event. She was praying for her wedding and she was able to afford a few things just because she stopped smoking. And those kind of motivation is what's really very, very helpful for them, and it's been very helpful. So we always give health education as part of our assessments. Most people know the dangers of smoking and why they should stop smoking. But once you keep hearing it over and over again, it's kind of just sits in there and rings a bell why they should actually stop smoking. At the moment, we've had training with the farmer outcomes, and I think we're almost ready to kick off by our start date, which is 29. What we've done with the farmer outcomes information we've gotten so far was print out the maps, expanded them, printed them out, got the postcode and the pharmacies around those areas. It's going to be easier or very easy for the patients to identify their streets and the pharmacy close to them and any pharmacy close to their postcode. which will really very helpful to the patient, because they know I'm just going to walk down to the pharmacy and get my NRT instead of waiting for a call from a community support. I don't even know where they're calling from. I think the common outcome is really going to help our inpatients that are willing to pay. So yeah, that's for the 12 weeks worth of calls that we also do. We do understand that the community is giving support, Pharma Outcome is giving support, and Be Well will be giving support as well. But at the moment, what we try to do is we run telephone clinics. Once we call them once a month, is not just to get data from them, but also to try and encourage them. Have you heard from this? Have you gone? Because one thing we've come to realize is sometimes they don't engage with the community services. So giving them a call once a month kind of from them, oh yeah, I'm going to give them a call, or oh, I lost their contact number, I need you to give me the number again. So it's been very helpful giving them that call and doing the telephone clinic. And I think that's basically all we do at the hospital at the moment, to try and get people to quit and stop smoking. At the end of the slides, if you have questions, you could always ask me and I'll give you the solution. Thank you.
Brilliant. Thank you so much, Alison and Florence, for a great overview of the service, and of course how the cure teams can help our patients. I'm now going to take us through a couple of slides around deployment in Greater Manchester and also farm outcomes. So as Alison already mentioned, Farm Outcomes has been procured by Greater Manchester IC on behalf of all NHS trusts in Greater Manchester. So all the trusts will be able to use Farm Outcomes for this service. Trusts have been engaged, and for those that have active cure teams in place, they are keen to go ahead to use the referral pathway as soon as possible. And we've got a number of trusts that are already live across Greater Manchester, which you can see there on the screen. So Northern Care Alliance in Royal Oldham, Fairfield, Bury, Rochdale and Salford Royal, also Royal Bolton, Royal Albert Edward in Wigan, the MFT groups of Wythenshawe, North Manchester General and the MRI, and also Stepping Hill in Stockport. Just next slide, thanks Al. So you can see many trusts have and are engaging with us, as Alison's already mentioned, and they're really keen to work with our community pharmacies to use this service. And you can see obviously probably the biggest reason why some of you have joined this evening will no doubt be this week's go live for TAMESIDE ICFT, which is due to go live on Wednesday the 29th this week. And you can see there's a number of other trusts that are due to come on board in the coming weeks and months as well. Next slide, please, Al. Thank you. So this slide, this shows the patient and data flow, and as you can see, it's quite detailed. So we will be making this available to you and your pharmacy teams after the webinar tonight. It does give a really comprehensive overview of the patient pathway, starting at the top there in blue. So this is what happens to the patient in hospital, and starting from when they're identified as smoker right the way through to when they leave the hospital and they're referred through to the pharmacy service, which you can see there in the green section in the middle. So the electronic referral is received by the pharmacy, by Farm Outcomes. And as Alison mentioned, the pharmacy is expected to contact the patient within 5 working days. Super important bit to remember. Please ensure that you're working within the requirements of the service specification, remembering that these patients, they've acknowledged that they desire to quit smoking and therefore engaging with the service and expecting the pharmacy to contact them to start their quit journey. And then it goes through into the sort of the support that you can offer the patients in pharmacy. So the 4 and 12 week quits, interim appointments, supply of NRT, if appropriate, to the point where hopefully we can then discharge patients following their quit attempts at 12 weeks. And then finally, as Alison already mentioned, the pharmacies do need to ensure that they submit information back to the trust and the GP via Farm Outcomes so that the patient records can be updated. Next slide, please, Al. Thank you. So just a little bit around Farm Outcome referrals then. So the service will always start with Farm Outcomes referral from the hospital to the community pharmacy. And that will show up in your Farm Outcomes the same way as it would do with DMS or CPCS. And the Farm Outcomes solution supports the hospital team to record patient demographics, quit date and details of any NRT that has been supplied at their end. And then this information is then sent to the pharmacy, so we have a full view of the patient journey so far. And then there's a series of modules for the pharmacy to complete. And the claim function, NYS, is now active, and as Al mentioned, will be sent automatically by the system. Next slide, please, Alison. So here we have some more detail about the data that we're recording in Pharm Outcomes, which is available to all pharmacies that have signed up to deliver the service. It's been set up as a linked template where you can record the patient's progress throughout their behavioural change support, and there's 5 different modules that you can use. So the initial intervention template, the interim appointment template to record weekly visits, the 4 and 12-week quit appointment to record patient outcomes. You've also got the onward referral mechanism. So should a patient want to use another pharmacy, for example, if they've moved home, or they want to use another pharmacy that's more local to them, or perhaps if your pharmacy no longer is able to provide the service, you're able to use this to refer the information securely via this template. And then finally, the mechanism to record referrals received by the pharmacy via email, so the manual entry option. Next slide, please, Al. So how do we accept a referral in Pharm Outcomes? It is slightly different to other referral services that you'll be using, in that the options are complete now option or reject option. So pharmacies must select the complete now to acknowledge the receipt of the referral and to confirm that they've either made or attempted contact. This is not the initial consultation with the pharmacist. This is about contacting that patient within 5 working days, as mentioned previously, and booking them in for that first consultation. So they do not run out of the NRT that's initiated in hospital. Please remember that this does not need to be done by the pharmacist. It can be done by any member of the pharmacy team. Hopefully you've all got fabulous staff members who are, keen dispensers, techs, ACTs. So if your pharmacists are struggling for time-wise, absolutely be getting those team members doing regular checks on Pharm Outcomes multiple times throughout the day. We see more and more patients being referred in this way now, so this should absolutely be becoming normal standard practice within the pharmacy. It's really important that these patients are expecting us to contact them. They're expecting a service from the pharmacy just as much as those who present in the pharmacy at the counter. And particularly for those patients who are accessing smoking cessation services, might have wanted to quit for a long time, but may not have got round to it. And it's absolutely our duty of care, if we've signed up to deliver the service, that we're able to deliver, and we're able to deliver within the agreed service specification requirements. If you contact the patient and they no longer want to quit, or the circumstances have changed, or you cannot contact them, you can reject the referral, but please do make sure that you give as much detail as possible when rejecting, so that commissioners and the cure teams, Florence and her team, they understand the reason for those rejections. We have had some feedback across some of the Greater Manchester sites that are already live, where pharmacies haven't followed that specification requirement. So I'm going to kindly ask Alison to come in and share some of that feedback that's been fed back directly to us.
Yeah, and we've had some great feedback. Some pharmacies are doing an absolutely fantastic job with this service. So following the service specification to the letter and following up on contacting patients and then providing that support. So I think when we last looked at the data around about a month ago, bearing in mind that the majority of these trusts only went live in January, I think we had almost 24-week quits so far, which was pretty good given that the data was so early. So some pharmacies have done a great job. But we just thought it was worth sharing with you an example that happened in one of the GM localities where a pharmacy didn't particularly do a great job, and it came with quite a negative outcome for the patient, unfortunately. So the trust had sent a referral to a pharmacy. The pharmacy hadn't done anything with that referral. Either they hadn't seen it or they hadn't made any contact with the patient. So the patient actually went into the pharmacy themselves to follow up and find out what was happening, because they'd not received a phone call from the patient, from the pharmacy, sorry. The person that they spoke to on the counter didn't know anything about the service, didn't believe that their pharmacy delivered the service. And the patient was therefore quite distressed about what had happened and ended up going outside and having a cigarette. So really, really poor experience for that patient, and completely the opposite of what we want to happen, because obviously we want community pharmacy to support patients to continue their quit attempts and to remain smoke-free. So Ricky and I had a chat about this earlier, and we thought it was useful just to share that example with you about how somebody who was really motivated to quit, really wanted to continue their quit attempt post-discharge, and got themselves into a bit of a stressful situation with the pharmacy because their team hadn't been informed and weren't aware that the service was provided. And then that caused really quite a negative experience for the patient. So really important, as Ricky said, get your team involved with this service. Make sure the people on the counter are aware, make sure all of your team's aware that you're delivering this service, get them involved in checking for referrals. And let's hope that we don't have any more negative patient experiences like that.
Well, thanks, Al. You can just go on to the next slide. Thank you. So currently, pharmacies that are recording their activity for SCS in farm outcomes will be getting this free of charge. At some point, we anticipate that farm outcomes will move SCS services to a provider pays model, at which point contractors will have to choose if they wish to continue to use the farm outcomes for a fee, which again, it covers the automatic invoicing via MYS, as we mentioned before. Next slide, please, Al. We do have a farm outcomes demo video available. However, we're not going to show it to you this evening as it's about 15 minutes long. And we appreciate you've all given up your evenings to be here, but we will make it available to you after. It just show a really good overview of the patient flow through farm outcomes. So it's super, super useful information, and we do encourage you to watch that in your own time. Here we've compiled what we believe to be some of the most helpful and useful resources for you and your teams to deliver the service to a high standard. So the video, as I've just mentioned, as Alison mentioned, the PSNC webpage, the service specification. There's also a link there to a recording of a webinar that we ran back in November. So if, for example, some of your team members couldn't make it to tonight, please direct them to watch this, or perhaps your pharmacy uses locum and relief pharmacists. Please make sure that they've watched it, that they're fully trained, they're aware of the service, and that they're able to provide the service should your regular pharmacist not be in. And lastly, the NCSCT standard treatment programme information that Alison mentioned before as well. Next slide, please. So thank you very much. I realise that's quite a lot of information for you to take in. Hopefully, we've managed to tell you everything you need to know for you to be able to confidently deliver the service. However, we will open it up to you guys now in the Q&A session. Not sure that I saw anything come through on the chat, Alison, but if anyone's got any questions, bring yourself off mute, ask away, drop something in the chat. We're happy to answer any questions that you have.
I have a question, if you can hear me properly.
Yes, go for it. Thank you, Sarah.
I have been sat here very, very quiet. So my only question is, within the 5 days, I say we've sent a patient to you and they're on day 3. So we've sent them home with NRT, but the trust is getting low, shall we say. So we're just on a bit of a low patch of NRT. So we've only sent them home with a week's supply of NRT. Is that patient going to be seen within them 5 days or within that week? Is there a time that they have to be seen, or is it just the 5 days for contact?
Thank you, Sarah.
Sarah.
Yeah, if you want
no, great question. So the reason for the 5-day limit is because we are aware that some trusts do routinely discharge with just a 7-day supply of NRT. So the purpose of that initial phone call should be, first of all, does the patient want to continue their quit attempt with the pharmacy, and give the patient a description of what the service entails? And second of all, to ask them how much NRT they've got left, and if they are running low, to make sure that that appointment is made so that they don't run out of NRT. So they're the 2 main purposes of that initial phone call. So it should be identified when the patient's followed up with that phone call within 5 days that they don't have very much NRT left, and therefore that initial appointment should be made within the next day or 2 to make sure that they don't run out.
Okay, I do have another question.
Go for it.
So my other question is, for people that get their pharmacy medications delivered, are they okay to do telephone consultations and then still have their NRT sent with their regular meds if that is their chosen pharmacy? Or will they absolutely need to come in at least once?
Another good question. So the service spec allows for pharmacies to deliver the consultations either on the phone or face-to-face as the patient requires. Home delivery is not an NHS commissioned service. So where a patient has their regular medicines delivered by a pharmacy, that is a private agreement between that patient and that pharmacy. So in that case, if the patient has an existing relationship with the pharmacy and already has a delivery, then it would be up to the pharmacy as to whether they would be happy to deliver that NRT alongside their regular medicines. And it might depend on frequency and things, because obviously for the SCS service, the pharmacy is only able to provide NR2 in 2 weekly amounts. So that might be a bit of an issue if they're getting their medicines delivered monthly. So that would be a conversation between the pharmacy and the patient, because that, as I said, that home delivery service is not NHS funded. It is a private arrangement between a patient and a pharmacy. So in theory, that would be possible, but it would need to be for the pharmacy to make that decision as to whether they're able to support that or not. It doesn't necessarily need to be the patient who collects the NRT. So it could be that the pharmacy could do the behavioural support over the telephone, agree the supply of NRT and have that ready. And then the patient could send somebody else to collect it on their behalf, a partner or a son or daughter or a neighbour or whoever. So that could be another way around it if they do have a patient who's housebound or not able to come into the pharmacy to pick the NRT up.
Thank you. Thank you very much.
No problem.
Thank you, Sarah. Brilliant questions. Does anybody else have any other questions that you'd like us to answer? Presenters, do you think, would you like to add anything else before we bring it to a close?
I think we must have covered everything, Ricky. Nobody wanting to ask us any questions. We must have done a very thorough presentation. That's what I can take from it.
Yeah, absolutely. Okay, then if there aren't any more questions, what we'll do is we'll bring the session to a close. So thank you so much for everybody for attending and giving up your evenings. What we'll now do is we will share the presentation and the video links and the resources that we went through with you. And thank you very much for attending.